It's been a while since I've posted a lecture, so I thought I would discuss polycystic ovarian syndrome. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Mosesjrk. This is a series on my YouTube channel where we look at medical topics in depth. In today's video, we're going to be looking at polycystic ovarian syndrome. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon to be receiving notifications of such amazing content every time I post. Grab a piece of paper, grab your pen, and let's go. So here's a warm-up question, which is a single best answer. You have just diagnosed a 21-year-old infertile woman with polycystic ovarian syndrome. The remainder of her infertility evaluation, including the patient's hysterosalpingogram and her husband's semen analysis, were normal. Her periods are very unpredictable, usually coming every 3 to 6 months. She would like your advice on the best way to conceive now that you have made a diagnosis. Which of the following treatment options is most appropriate first step in treating this patient? A. Dexamethasone. B. Gonadotrophins. C. Artificial insemination. D. Metformin. E. In vitro fertilization. You may scream at your screen, write down your answer. I will give you the answer at the end of this particular lecture. Before we actually dive right into polycystic ovarian syndrome, it's very imperative that you actually know a little bit about the ovaries and the follicles that we find inside the ovaries. Remember that the reproductive organs in the female are two, the gonads are two ovaries, and each of these ovaries is going to be this solid ovoid structure that's roughly as their following dimensions, about 3.5 centimeters in length, 2 centimeters wide, as well as 1 centimeter thick. And these ovaries are going to be found in this depression, which is referred to as the ovarian fossa, and they're going to be on the sides of the uterus, in the lateral walls of the pelvic cavity. They're going to be held by these loose, or rather peritoneal ligaments, and the ovaries are responsible for production of estrogen, which does come from the granulosa cells, progesterone, which comes from something that's known as the corpus luteum, and of course androgens, which can also be produced from the theca cells. And remember, androgens also in the female body can also be produced from the adrenals. Remember that the ovaries are going to be have a covering epithelium, and they'll have a parenchyma and they'll have a stroma. Remember that the parenchyma is the functional unit of an organ. In this case, it would be the ovarian follicles that happen to be the parenchyma. Then the stroma is pretty much the connective tissue. So on the outside, they're going to be covered by a layer of simple cuboidal epithelium, which is what we refer to as the ovarian epithelium, or some books refer to it as the germinal epithelium. Remember that this is going to be the visceral peritoneum, and it's going to be enveloping the ovaries. Underneath this, you have a dense layer of connective tissue capsule, which is known as the tunica albuginea, and the substance of the ovary itself is going to be divided into two halves, what we refer to as the cortex and what we refer to as the medulla. So the cortex is going to be this dense granular section which has the functional tissue of the ovaries, the ovarian follicles, and each of these ovarian follicles is going to be found in various developmental stages, and each follicle is going to be consisting of an oocyte, which is the female germ cell, and the medulla is going to be largely consisting of the stroma. So it's going to have connective tissue with this abundant blood vessels, as well as lymphatics and nerve fibers. Here's a picture to show you. So you have like a cuboidal epithelium, which is covering the ovaries. Then you have the cortex, which is what's depicted in yellow, which has the different ovarian follicles in different stages of development. Then you have the medulla, which pretty much consists of the neurovascular structures, the nerves, the blood vessels, and the lymphatics. Then of course you have the hilum there. So this is a basic structure of an ovary that I want you guys to keep in mind, because even when we discuss ovarian tumors, they may arise from these different particular structures. So before I also get into polycystic ovarian syndrome, I'll talk a little bit about oogenesis, which is the process of production of these female reproductive cells that happens in females. So remember that these sex gametes as well as sex cells are going to be developing in the ovaries by meiosis, which is referred to as oogenesis. It's a bit similar to what happens in the males in terms of spermatogenesis, but the timings are a bit different and the final result is also different. Remember that the oogenesis is going to be happening in the early fetal life, and you have these primitive germ cells in the ovaries that are going to be differentiating to what we refer to as oogonia. So as these oogonias form, they're going to be rapidly dividing to about thousands of cells, and they're going to be having the full complement of the chromosomes. They'll have the 46 pairs of chromosomes. So they'll have 23 pairs rather of chromosomes, making 46. That's a full complement, what we refer to as a diploid state. Now these oogonia can then enter into a growth phase, and they can enlarge, and then they form what is known as a primary oocyte. These primary oocytes are going to replicate their DNA, and then they're going to enter into meiosis. So they enter into the first meiotic division, and then it's going to stop at the stage which is known as the prophase. And this is going to stop until the female reaches puberty. So it means from the time a female is born up until puberty, the cells in the ovaries are going to be arrested in the prophase. So it means that there's a higher chance of mutations happening, especially if this woman is exposed to a lot of radiation or these other risk factors that may cause mutations, which is why it's much more likely to have mutations arising from the oocytes than it is with spermatogenesis, because spermatogenesis happens a bit differently and the timings are a bit different. So many of these primary oocytes are going to degenerate before the child is actually born, and the two ovaries could have roughly approximately 700,000 oocytes at birth, and this is actually going to be a lifetime supply where they're going to have these cycles when they attain menarche up until they reach menopause. And remember that unlike with spermatogenesis, which happens to begin at puberty and then carries on until the rest of the life, oogenesis usually is going to be limited to the number of these oocytes that are present, such that by the time this person reaches puberty, they're going to have the oocyte number roughly around 400,000. So at the beginning of puberty, the anterior pituitary gland is going to be producing a hormone that's known as follicle-stimulating hormone, or FSH. Now, this is going to be causing changes in the type of follicle that is referred to as a primordial follicle, these small ones here. And these primordial follicles are going to become cuboidal, and the primary oocyte is going to enlarge, and then you now refer to it as a primary follicle. So remember, these primary follicles are going to be responding to follicle-stimulating hormone that is coming from the anterior pituitary gland, and they're going to proliferate. They're going to form several types of layers of cells around them, which we refer to as granulosa cells, and these granulosa cells are going to be around this primary follicle. Remember that most of these primary follicles are going to degenerate with the primary oocyte within them, but some of them are going to develop further. So you're going to have one that's going to develop into a mature follicle, which is known as a Graafian follicle, and eventually it's going to be ovulating an oocyte that may or may not be fertilized. So remember that these granulosa cells that are surrounding this primary follicle are going to be starting to secrete estrogen, and a cavity can sometimes form. With this cavity is known as the antrum, can sometimes form within the follicle. So when you have this antrum that's actually forming within the follicle, we no longer refer to it as a primary follicle. We're now going to be referring to it as a secondary follicle. Now, this secondary follicle can sometimes start, the granulosa cells around it can sometimes start producing a certain glycoprotein that's going to be forming a clear membrane that we refer to as the zona pellucida, which is going to be found around the oocyte. And then eventually, about 10 days of growth of the follicle, it's going to mature into what is known as a Graafian follicle, a mature follicle that can be forming a blister on the surface of the ovaries, and then this can be ovulated. So the secondary oocyte is then going to be ready for ovulation, and this roughly happens around day 14 of a 28-day cycle. So remember that ovulation, just before ovulation happens, is going to be a surge of another hormone that's known as luteinizing hormone, or LH, which is also going to be produced from the anterior pituitary gland. And this is going to be happening, and it's going to cause the mature follicle on the surface of the ovary to rupture, and then this is going to release the secondary oocyte into the peritoneal cavity. Now remember that the ovulated secondary oocyte is going to be ready for fertilization, but it still will be surrounded by the zona pellucida and a few other cells, which is what we refer to as corona radiata. It looks like a crown. And if fertilization doesn't take place, then this oocyte is going to degenerate in a couple of days. But if the sperm actually passes through this corona radiata in the zona pellucida and it actually enters into the cytoplasm of the secondary oocyte, then this secondary oocyte will reinstitute the second meiotic division, and then this is going to resume to form what is known as a polar body and as well as a mature ovum. So after this ovulation has happened in response to luteinizing hormone, remember you leave behind a structure inside the ovaries, which is what is depicted here. This structure is known as the corpus luteum. So this corpus luteum that is remaining inside the ovaries is the one that's going to be responsible for production of progesterone and to some extent some amount of estrogen. It's meant to actually keep the endometrium ready for implantation, and in an event that fertilization doesn't take place, then this corpus luteum is going to die off. It's also going to live for a fixed number of days. And once this corpus luteum has begun to die off because fertilization has not taken place, there's no implantation, and then this is going to lead to shedding off of the endometrial lining, and this is what leads to menstruation. So if the fertilization doesn't take place, the corpus luteum can remain functional for about 10 days, then it will begin to degenerate and it forms what is known as the corpus albicans, like a white body. And this forms like primary scar tissue and the hormones actually decrease. So if fertilization does take place, then the corpus luteum is going to persist, and then the hormones are still going to be produced until the placenta can take over the role and start producing the necessary hormones. Then afterwards, the corpus luteum is going to degenerate into the corpus albicans, but it may sometimes remain functional for a much longer time. Now, when you talk about polycystic ovarian syndrome, we're just simply referring to these multiple follicular cysts in the ovaries that are going to be due to hormonal imbalance. Remember that this ovarian follicle is going to be consisting of a developing follicle that's going to be surrounded by one or more layers of cells, which we refer to as follicular cells. Now, at the same time that this oocyte is progressing through meiosis, you have these corresponding changes that are also happening in the follicular cells. So the primordial follicles, which are going to be consisting of the primary oocyte surrounded by this flattened single layer of cells, are going to develop into the fetus and are the stage that is present in the ovaries when someone is born and throughout childhood. Then eventually further development is going to carry on when this child reaches puberty. Now remember that with polycystic ovarian syndrome, the condition is going to be affecting 5% of reproductive women, and this is going to be seen in about 20% of normal women. How exactly does this come about? Remember those two hormones that I talked about that are produced from the anterior pituitary gland, namely follicle-stimulating hormone and luteinizing hormone. So there is an imbalance between these two hormones. There is increase in production of luteinizing hormone and there is low production of follicle-stimulating hormone. And if you actually look at the ratios of these two hormones, you'll find out that LH to FSH ratio will be greater than 3:1. Now remember what these hormones are responsible for doing. The FSH is responsible for the maturation of those follicles from those primary oocytes and eventually maturing into a mature Graafian follicle. And the luteinizing hormone is essential for ovulation. Now remember, once you have these high levels of luteinizing hormone is going to stimulate a special type of cell that is surrounding these oocytes to stimulate these cells to produce androgens. And these type of cells that produce the androgen are known as the theca cells. So this woman is going to be having high levels of androgen in her system. Now this is going to be also further worsened owing to the fact that the adrenals are also going to be producing some amount of androgen. So this person will have hyperandrogenism or hyperandrogenemia, or a lot of androgens in their system. So this excess androgens can sometimes result in excessive hair growth, which may resemble a similar male pattern of hair growth, which is what we refer to as hirsutism. And some of this excess androgen can be converted by fat tissue, the adipose tissue, into a type of estrogen that is known as estron. Remember that estrogen, there are predominantly about 3 types of estrogen. There's estron, there's estradiol, and there's estriol. So your androgens that are going to be converted mainly by the adipose tissue into a type of estrogen that is known as estron. This is very common, especially in obese individuals. So these patients actually have large amounts of estrogen. Now remember that estrogen has this negative feedback on the pituitary gland, and it's going to inhibit FSH because the pituitary gland is going to take it in a way that a follicle has matured and it's starting to produce all this estrogen. So let's stop producing FSH to prevent further other follicles from developing. So you have a lot of this estrogen that is coming from other sources that is causing this negative feedback in the production of FSH. And as a result, now your granulosa cells can no longer convert your androgen into the estradiol, which is what these granulosa cells are going to be producing. Granulosa cells will produce the special type of estrogen that is known as estradiol. So as a result, these follicles are not going to be stimulated by the FSH. They'll have insufficient amount of estrogen to maintain and to develop the follicle, so they begin to degenerate and they become cystic, resulting in polycystic ovarian syndrome. So what pathology do we expect? We're going to see that the ovaries are going to be enlarged. The ovarian volume will be greater than 10 cubic centimeters. The stroma is going to be increased. The capsule is going to thicken, and the ovaries will be pearly white in color. You may have the presence of multiple, more than 11 follicular cysts that are measuring about 2 to 11 millimeters in diameter, and these are crowned around the cortex of the ovary. Now, what clinical features do we expect to see in an individual that has polycystic ovarian syndrome? You may get the classical presentation where you get an obese young woman with this abdominal obesity in 50% of the cases. There may be some infertility because ovulation will not be taking place. There is no mature Graafian follicle because FSH is not there in the first place to stimulate this maturation. You have high levels of estrogen, and then of course, even though LH is there, there is nothing to ovulate because there is no mature Graafian follicle. You may have the menstrual abnormalities such as oligomenorrhea or amenorrhea in 70% of the cases. You may have hirsutism, you may have acne, which are pimples in 70% of the cases, and of course multiple cysts that you can see on ultrasound. Patients may also have this velvety-like skin that you may see that's very common at the nape of the neck, the inner thigh, as well as the groin and the axilla. We refer to this as acanthosis nigricans, and of course these skin changes are attributed to the insulin resistance that we often see in these patients that have polycystic ovarian syndrome. So the skin is going to be thickened and it's going to be pigmented grayish brown. Here's an image of what acanthosis nigricans actually looks like. So polycystic ovarian syndrome is one of the causes of acanthosis nigricans. It's also seen in type 1 type of diabetes, mellitus of course. So some patients can develop insulin resistance, rather type 2, not type 1. Can develop insulin resistance, and it's seen with type 2 type of diabetes. So in future, these patients with polycystic ovarian syndrome are going to have increased risk of hypertension, increased risk of cardiovascular disease, increased risk of endometrial cancer because of the high levels of estrogen that are circulating in their system. There's going to be increased risk of ovarian cancer. And remember that the risk of endometrial and ovarian cancer is going to be reduced by the risk of oral contraceptive pills. They may also have what is known as the hair-ant syndrome, where they have hyperandrogenism, a lot of androgens in their system, features of insulin resistance, and acanthosis nigricans. Again, here's a picture of acanthosis nigricans. Now, what are some of the biochemical abnormalities that are going to be associated with polycystic ovarian syndrome? You may have a lot of androgens in the body, hyperandrogenemia. You may have a lot of insulin, hyperinsulinemia, because there's insulin resistance that is there. There may be hyperlipidemias, high serum estrogens like estradiol and estrone. There may be androgenic follicular microenvironments. You may have a hyperprolactinemia that may also contribute to the infertility. You may have hypersecretion of the luteinizing hormone, low levels of the sex hormone binding globulin, low levels of FSH, low levels of serum progesterone. To make a diagnosis, you need any of these two. A patient with either oligomenorrhea or amenorrhea, together with hyperandrogenism. It could be clinical where it's manifested by hirsutism or some biochemical changes, or they should have some polycystic ovaries on ultrasound, 8 or more subcapsular follicular cysts less than 10 millimeters in diameter, and an increase in ovarian stroma. You should exclude other causes such as your thyroid dysfunction, such as your hyperprolactinemia, and even your Cushing's syndrome. Investigations include a hormonal profile, which is going to be showing that the levels of luteinizing hormone are greater than the levels of follicle-stimulating hormone, such that the ratio is greater than 2 to 1. Some books even say the ratios will be greater than 3 to 1. There will be a rise in the levels of estradiol and estrogen is going to be markedly elevated. The levels of the sex hormone binding globulins are going to be reduced. There will be raised levels of serum testosterone and dihydroepiandrosterone. I don't know if I say that right, but it's DHEA, and this is going to be marginally elevated. The serum testosterone are going to be elevated. When you do a transvaginal ultrasound, it's going to be much useful in obese patients, and the ovaries are going to be enlarged greater than 10 cubic centimeters in volume, and they'll have an increased number of these cysts, which are about 2 to 9 millimeters in size and more than 12 of them. You can do a laparoscopy, which is going to show you this bilateral polycystic ovaries, and this is going to be characteristic of polycystic ovarian syndrome. Now, how do you manage these patients? Remember that treatment is often individualized, and it's going to depend on certain things. It will depend on the presenting symptoms. It will depend on the menstrual disorders that are present, infertility, obesity, hirsutism, or a combination of the symptoms. Often, you should be able to counsel your patients. Weight reduction is very important. So their BMI should be less than 25, and this has been shown to improve the menstrual disorders, to improve the infertility, to improve the impaired glucose tolerance and the insulin resistance, and also helps with hyperandrogenemia, which is going to be what's causing the hirsutism and acne. It also helps with the obesity. So weight reduction improves the metabolic syndrome as well as improves the reproductive function. You should advocate for this in your patients. Dietary modifications can also be done, and if they do have hirsutism, a flonithine cream can be applied topically. Cyproterone acetate can be used. Metformin, gonadotrophin releasing hormone agonists with low dose regimens can be used. The hormonal replacement therapy regimens can be used, and these are reserved for women that are intolerant to other therapies. Sometimes you can use some surgical treatment like laser or electrolysis. In terms of patients that want to get pregnant, we can use ovulation induction agents like clomiphene citrate that can stimulate ovulation. Metformin, given at 500 milligrams 3 times a day, can improve the metabolic syndrome because it's going to be reducing all the parameters. It will reduce the weight, it will reduce the BMI. So this means that even the hyperinsulinemia and hyperandrogenism will be helped. The blood pressure is going to be affected, and it's going to help control the blood pressure to some extent, even the lipid abnormalities. Pioglitazone and rosiglitazone are being used, especially for those patients that are resistant to metformin. In terms of patients that do not desire fertility, combined oral contraceptive pills can be used. Remember that the progestins are going to be suppressing the luteinizing hormone, while the estrogen is going to be improving the sex-binding globulin. It's going to reduce the free testosterone levels, but now we can use newer progestins like desogestrel, which are better suited to regulate the menstruation. Some anti-androgen drugs like cyproterone acetate, spironolactone, and flutamide can also be used, and of course metformin can be used to correct the metabolic syndrome and reducing parameters like the weight, the BMI, the blood pressure, as well as the lipid abnormalities. Coming back to our warm-up question, you have just diagnosed a 21-year-old infertile woman with polycystic ovarian syndrome. The remainder of an infertility evaluation, including the patient's hysterosalpingogram and her husband's semen analysis, were normal. Her periods are very unpredictable, usually coming 3 to 6 months. She would like your advice on the best way to conceive now that you have made a diagnosis. Which of the following treatment options is appropriate first step in treating this patient? So you would obviously refer to this patient to start on metformin. I really hope you enjoyed this video on polycystic ovarian syndrome. If you did, consider subscribing to the channel, hit the bell notification icon so you never miss on such amazing content every time I post to Zambia and beyond. My name is Dr. Moses Kazevu. Until next time, bye-bye.